Good evening, everybody. I know we are coming to the fag end of the day, and all of us are getting ready to go home. And it's not a topic that might interest everybody. But the topic for today was optimizing post-treatment in pediatric cancers. And I have three musketeers in the field of pediatric hematology with me to take it forward. I have Dr. Dheenadayalan, a pediatric hemato-oncologist and a bone marrow transplant physician from Dr. Rehabilitation Hospital, Dr. Arun Seshachalam from Trichy, and Dr. Dhaarani Jayaraman from SRMC. Yeah. So I'll not waste time introducing everybody because they are quite well known in our pediatric oncology team. So we'll just go ahead with the talk. The survival rates of, it was about a couple of years back, in probably the years that I was born in the 1960s, when a diagnosis of malignancy in a child was done, it was probably death sentence because the survival rates were in a single digit. But we have traveled a long way from there. In 2000s, in this century, we have a very good results. It's very heartwarming to see such results. Such results are because of the probably increased awareness of the disease, early pickups of increased awareness of the disease, early pickup and diagnosis, and then the advancements in oncotherapy that we have, various new drugs that we have come in from 1960s to now, the advent of radiotherapy, and recently we are walking into another era of immunotherapy in malignancies. So what we started off as desperately trying to pull back the child from towards a child traveling towards a grave, to giving a child a quality of life today. So what has started like somehow try to save the child at that moment has come on to a case like in all the corporate sectors, we have started doing customized therapy, individualized therapy, fitting to every child. So stratification, the advancements in risk stratification, the various molecular diagnoses that are available, the genetic workups done, and with the advent of CAR T therapy, things are going to a different level when we customize and treat every child only to what is needed. So when we were talking about, when I was doing my undergrads or my postgrads, it was like upgrade at the end of 4 weeks if the patient does not respond to your treatment. But now it has come to down-regulate at the end of 4 weeks if you think you're gone into remission. So that is where we stand now. So we are all going towards giving what is called a quality of life to these people. I think the slides are not ready. I think we'll just go ahead with the talk. So we just split up into few major questions that we commonly encounter. See, this is the care of these children. Pediatrics particularly is usually a shared care. So optimizing treatment requires the shared care of the pediatricians with the oncologist at all stages, from the stage of diagnosis to the stage of follow-up. So I'll just stick to the follow-up because optimizing post-care is the topic for today. So the pediatrician, invariably the child goes back to the pediatrician and a lot of questions start there. And how are we going to follow up these child? How are we going to make sure that they do not have the side effects of all the drugs they were given, the radiation that they have given, and should we fear that the disease will come back? These are the things that we have to optimize. So this is what we are going towards. So in this group, we should not be able to make out who underwent therapy for any malignancy a couple of years back. They should look as normal as any other children. So the first question is, malignancy per se. In a country like India, the most common things even during chemotherapy, cause of mortality and morbidity is sepsis or infections. So malignancy per se causes a lot of immunosuppression, and the drugs and the radiation that we add to it causes more immunosuppression. So first let us see the common things. How are we going to protect them post-therapy? Are they we going to treat them of the disease, or are we going to give them off to an infection? And what is the role of vaccination post-treatment? Dr. Dheenadayalan, can you take up this question, please?
Okay, thanks for everyone for inviting me, and also those who are sitting here, thanks a lot for delegates also sitting here. I can count only around 15 of here, so it's very closed door meeting. So we'll start with an. Okay, thank you for this question. And immunosuppression varies between the disease to disease. Suppose we take an acute leukemia patient, they're very prone for an infection because of severe suppression of the cellular and humoral immunity. Whereas localized solid tumors, they'll have hardly any deficit there. So same thing, so immunosuppression depends upon the dose and degree and type of chemotherapy also. So what a immune reconstitution usually occurs between after 3 to 6 months after the end of the treatment. So usually T cells full restoration occurs between 1 to 2 years of age, and IG levels usually suboptimal during the chemotherapy, and then they'll become normal by 6 to 12 months, and NK cells will become normal by 3 to 6 months. That is the reason only we'll start the immunization 3 months to 6 months after the end of the treatment. So usually when you go for an, how do you decide which vaccination should be given? The first is some drugs can be, some vaccination can be given during the chemotherapy phase, like inactivated influenza vaccine can be given annually. And other thing is whether this vaccine is whether the child already received before the cancer diagnosis, or it's not unimmunized. And based upon that, we can give the immunization schedule. And most important thing for the general pediatrician is, suppose the immunization of the contact with the children with the cancer. Suppose a sibling, you can give all the vaccine like a killed vaccine and live vaccine except polio vaccine. So never give an oral polio vaccine, and then you may give rotavirus. So this is a way you are going to manage the patient who have a post-chemotherapy.
The next common thing is, even nowadays, a lot of children, the endocrine OP is filled with a lot of children with hypothyroidism. So these children who have undergone cancer chemotherapy, or the survivors of malignancy, how common is it in that population? And post-therapy, how frequently should we monitor all these patients?
Okay, so that's an excellent question. Actually, the endocrine glands which get injured during the course of chemotherapy is first is pituitary hypothalamic axis, second is thyroid, gonads, and then pancreas. So it's also what are the why is the reason most of the endocrine problem may be because of the injury to the hypothalamic pituitary axis, or pituitary glandular, or like a peripheral glandular glands involvement. So what are the things mainly happen will be either will be an hypothyroidism or hyperthyroidism and goiter also. Some of the patient who receives the radiation to the neck and mantle neck radiation as part of Hodgkin's lymphoma, they're very prone for secondary thyroid malignancy, and usually happens between 2 to 4 years after the post-treatment. And even the patient who receive the TBI and busulfan-based conditioning, they are also very prone for hyperthyroidism. So you should annually should monitor for the thyroid function, and also you monitor for the nodules, especially those who receive the radiation. So for the by ultrasound, so they look for any secondary malignancy in the.
This is a survivor. We have a lot of children entering into adolescence, and now it's the thing of going into hitting the gym. And I see a lot of these adolescents coming back and asking, can I take HIIT? That is high intensity exercises. So are these children fit enough to take these exercises? Or because we read in the paper every day, even a normal person collapsing in the gym. So do they have to be evaluated before we give them a green signal? or indirectly, what are the cardiopulmonary effects that we need to monitor?
So both chemotherapy and radiation in alone or in combination will cause disease in the cardiovascular system. Slides. So cardiovascular system. So it's a most common cause for morbidity and mortality next to the cancer recurrence and the secondary neoplasm. So that's the most important thing. What child received chemotherapy during the treatment, which if suppose the patient is anthracycline and cyclophosphamide, so these children are you have to monitor. So anthracycline usually affects the cardiomyocytes, so that will causes the heart failure and the cardiomyopathy in the future. So usually, if those children who receive chemotherapy less than 5 years of age, they're very prone, and they would receive the cumulative dose of more than 250 to 300, they're more chance. So I think it's how you monitor. If it's less than 15 grays and no anthracycline, no need for screening. And every 2 years, the child will receive 35 gray and no anthracycline, and 15 gray and 25 milligrams of meter square more than cumulative anthracycline. Every 5 years, if it is 15 gray but less than 35 centigrade and no anthracycline. So these are children you have to monitor with an ECG and echo and cardiac stress test. Usually anthracycline causes the QT interval, and echo will monitor for the SF, and then you look for ejection fraction. Suppose there is a drop in ejection fraction when compared to the previous more than 10%. These are children you have to follow up very regularly. So this is the way you have to monitor the patient, and even the pulmonary system also. Those who receive chemotherapy like an busulfan and this others also patient will go for a cardiopulmonary, so pulmonary complications. So these are patients should be monitored very frequently and should do the proper screening.
So any adolescent who wants to hit the gym should undergo a cardiac evaluation, particularly those cancer survivors?
It depends upon what dose of chemotherapy and how long is going to get it. And based upon, you should take a decision. That is the main job of the pediatrician. They should only decide on the what is the dose child has received previously.
Thank you, Dr. Dheenadayalan. This question, I will pass it on to Dr. Arun. This is the most common question, not only in an Indian scenario, I think everywhere. So the first thing when we say a girl child is diagnosed with malignancy, the first thing that the grandfather asks is, can she get married? Will she have children? So progeny. So can we expect normal fertility in these children? And what are the ways ahead? Is there ways that before giving the chemo, can we freeze the ovum or the sperm? Is it being done on a regular basis in India?
Okay, thank you very much for this question. So in childhood cancer, if you take the childhood cancer when compared to adult cancer, most important thing is 80 to 90% can be cured, which means that where in adult, where only we have a chance of 40 to 50% cure, nearly 80% of the kids are going to survive and they are going to become a survivor. So it is not important that we are going to treat the child only during the illness. We need to think far ahead. We need to think that 80% of the time they are going to live after 5 years and they are going to have late side effects. Okay, they are going to marry, they are going to procure child, they are going to go for work. So we really need to think of all the late effects before we plan the treatment. That's why Madam was clearly telling, you should not over-treat. You should not under-treat. You should provide optimal treatment. Okay. So many times when we become emotional, when we get attached, we tend to over-treat. But it's important that these things can have late effects. So always it's important that we think the late effects when we treat a childhood malignancy, because 80% of the time they are going to live. Second thing is, because it's a mixed crowd, why this happens? Okay. So cancer cells is a rapidly dividing cells. Okay, it's dividing very, very fast. Most of the therapy, that is 3 therapies we have. One is chemotherapy, another is radiation, next is surgery. Only 3 armamentarium we have. Okay, so all these things affect the rapidly dividing cells. So it is not going to kill only the cancer cells. It's going to kill any cells that is actively dividing. So which are the cells that is actively dividing? When you take a kid, in the first 3 years, which is the organ which is rapidly growing? Brain. So it affects the brain. So cognitive problem can happen when we give chemo or radiation during the early age. Okay. what happens during the growth spurts, 8, 9 years when the spurt rapidly dividing apart from the cancer cells, it's the bone and skeletal growth. So that time we give chemotherapy, cancer cells, along with that growth retardation will happen. What happens after puberty? It's the germ cells. Maximum functioning is ovary and testis. That is the actively dividing cells. So whenever we give chemo or radiation after puberty, okay, not only the cancer cells, germ cells also will be affected. So that is why this infertility problem happens. So this is the concept, okay, why a child develops infertility after treatment. So again, what are the factors? What are the factors that decide? So one is the cancer per se, because the cancer may be in the ovary or testis. When the cancer is affecting directly the organ that is producing the germ cells, then definitely there will be a chance of infertility. That is the first. So a child having a germ cell tumor or testicular malignancy per se, even without treatment, can have infertility during the later day. That is the first point. The second thing is because of the treatment what we are giving. Okay, so if you take the surgery, okay, many of the time if the child is having ovarian cancer, we tend to remove the ovary. So because the child is removed of the ovary, child may have infertility. Okay, here again, unlike adult cancer, in pediatrics, we can preserve both the ovary. If the patient child is having ovarian malignancy, you can give chemotherapy, we can totally cytoreduce and we can preserve the ovary. There are a lot of things called fertility sparing surgery. Even if the child is having involvement of ovary due to malignancy, we can spare it by giving chemotherapy and spare the ovary. Okay, so one is because of the treatment what we are giving. Next is chemotherapy. When we are planning to give chemotherapy, particularly post-pubertal, we can select the chemotherapy what we give. When we take the chemotherapy, two important chemotherapy what I feel is, one is alkylating agents and next is topoisomerase inhibitors. These are two important agents I am very, very concerned. If at all there is a possibility, I can plan the child's treatment reducing the dose of the alkylating agents or substituting the alkylating agents, then it's fine. Important is cyclophosphamide, ifosfamide, lomustine, procarbazine. This problem comes to me whenever I treat a Hodgkin's lymphoma child, a post-pubertal child coming for treatment. Okay, when I am planning treatment, I try my best to avoid procarbazine and try to involve chemotherapy which avoids procarbazine. Like there is a hybrid chemotherapy regimen, COP regimen, all these things I try to avoid when I treat a child after puberty. So I try to do ABVD chemotherapy. So this is the chemotherapy. So one is surgery, next is chemotherapy, last is radiation. Again, whenever we treat the child with radiation of the pelvis, we try to take that or like ovary outside the field of radiation. Okay, so few kids, what we do is, when we give RT to the pelvis, particularly in case of Ewing sarcoma or rhabdomyosarcoma, we try to do a surgery, laparoscopic surgery, we try to take the ovary outside the radiation field so that that radiation does not affect the ovary. So, one, it can be because of the malignancy per se. Second is, it can be because of the treatment what we are giving. Both can cause infertility. During my own one paper in Cancer Institute when I published in the late side effect of survivors, we found that 25% of the childhood survivor had infertility. 25%, that is 1 out of 4 kids can have infertility at a later age group. So how to prevent this? That's the second part of the question madam was asking. How can we avoid? One is by preserving the germ cells. Okay, if it's a post-pubertal male, in male it's very easy. Okay, just the thought is important. Okay, as an oncologist, before treating, because there will be a lot of emotions involved when a child is coming with leukemia or Ewing sarcoma, a lot of emotions. So we should not rush treatment. We should always think of late effects. Make sure that you know that 80 of the 100 is going to survive. So if it's a male, it's easy. Okay, they can always go for sperm analysis, sperm banking. It is very easy. Just it will delay the treatment by 3 days. If it's a female, post-pubertal female, then we need to discuss with the family members. We should involve the endocrinologist. We should involve the infertility specialist. Many times, if we have 2 to 3 weeks time, if the cancer is not aggressive, we can wait 2 to 3 weeks time, because in leukemia or Burkitt's, you cannot wait 3 weeks. If we have that 2 to 3 weeks time, we can involve a gynecologist. Okay, we can do the oocyte retrieval, preserve the oocyte, then we can start the treatment. This is for post-pubertal females. Pre-pubertal, as I already said, before puberty, the infertility chances is less. Okay, because the germ cells are not dividing. So if you give chemotherapy, the infertility problem is less. But still, if you want to really be safe, you can always take the ovarian tissue and testicular tissue and cryopreserve. But still, all these things are in experimental stages. I am not using routinely these particular methods. Post-pubertal, yes. For all post-pubertal male, I do sperm preservation, sperm banking as a protocol I do. Females, I discuss. If they are okay, I refer to the endocrinologist, gynecologist, do the oocyte retrieval, preserve the ovum for a later date. Thank you, ma'am.
Thank you. That is human intelligence for you. So we started thinking about long term, giving them a happy, normal life. Dr. Arun, again, since you talked about intelligence, radiation, these survivors, should we expect them to be subnormal, or they can also become an hemato-oncologist?
Okay. So they can become a hematologist because I know, actually I know, like a cancer institute during 2003, the child who I treated, he passed his MBBS, he's in MD, he wants to become an oncologist. Okay, they can. Okay, he's a AL leukemia, he received whole brain RT and high dose methotrexate.
I remember there was one person in ICH who did MD.
Yes. Okay, fine. So it's possible to become, not even hematologist, he can become the Prime Minister of India also. Okay, so it's not a great thing. Anyway, so as I rightly said, it affects the rapidly dividing. When any treatment that is given in the first 3 years, okay, can really affect the cognition. Okay, as I said during the infertility, first it can be because of the cancer per se. When the cancer is in the brain tumors, or when there's a leukemia involving CNS involvement, it per se can cause cognitive problems. Even at baseline, they can have cognitive problems. Okay, not because of therapy. That is first. Second, it can be treatment related. Okay. Two important treatment related side effects is, one is cranial radiation. Cranial irradiation is the most important because our team during my thesis was neurocognitive problem, which I published in IJMPO in 2010 journal. It got published. Okay, when cranial irradiation, particularly 18 gray, which this was the protocol which initially we used to follow, there was a significant cognitive dysfunction was noticed. During my study of 54 kids, we found significant decrease in the cognition from baseline to the 6 months and 1 year analysis. Almost 34 to 40% had decrease in the cognition, particularly in case of fine motor and visual memory. These are two domains which was affected predominantly. So whenever possible, avoid whole brain RT. That is what Madam was telling, optimize the treatment. Just because you want to avoid CNS involvement, CNS relapse, don't give radiation to all the kids. Try to optimize, try to risk stratify. Okay, now molecular testing, everything is available today. So there is no reason tell that I didn't risk stratify initially, so I want to give everything. That should not be. Okay, so we need to personalize treatment. Wherever possible, avoid whole brain RT. If at all possible, try to reduce the radiation to 12 gray or 8 gray. Okay, so 12 gray is what we are now using. And when we give high dose treatment, particularly high dose methotrexate and high dose cytarabine, it has cognitive problem, but less than whole brain RT. But when we give whole brain RT plus high dose methotrexate, both are combined, then cognitive dysfunction is even more higher. Okay, so all kids who received high dose treatment, either it's high dose methotrexate, high dose cytarabine, or high dose chemotherapy and transplant, all kids who received whole brain radiation, definitely you need to have a baseline assessment. Okay, at least the child, once the induction is over, child is fine, a baseline neurocognitive assessment and serial assessment at 6 months and 1 year really can pick up the kids who require therapy at a later point of time.
This is a very sensitive question. So, if the child treated by you comes with a partner asking, can I marry, or how do you counsel them?
Okay. So, this child is no more a patient. I think child is not a patient. We all know. The child is a survivor or conqueror. This is the word. They become a friend to us. So most important thing I tell myself is I am a facilitator. I am no person who is going to tell you should marry or not to marry. Okay, it's a marriage is between two individuals. Okay, I am just there to clear their answers or questions. I try to avoid anybody calling me that this person came, gave you a number, he has, is there any problem? I try to tell that there's a confidentiality is there, we won't tell anything regarding the survivor, that is first point. And second thing, anybody walk into my chamber, I tell that the survivor has asked me to go and meet, I am his fiancé or her fiancé, I try to avoid. So I make sure that both of them come to my chamber, that is first thing. I see two things. One, already they have decided they are going to marry, then they are just giving an invitation to me. Okay, I am no person to tell anything about the cancer or treatment. Okay, so are they going to give the invitation or inviting me to the marriage? That is first. Or they have come to counseling. If they are coming to the counseling, then I address the specific issue what they are asking. I don't tell more, I don't tell less. This is what the principle I follow in my practice.
I totally agree, because when they've already made up their mind, I'm sure they've discussed with each other. I think we just have to be catalyst. This question to Dr. Dhaarani. See, a lot of things, we talk a lot on metabolic syndromes. We have children walking into the pediatric clinic at the age of 10 with a weight of 80 kilos, 90 kilos. So those are normal children. But these are children who are, as we've already discussed, a lot of endocrine hazards because of the treatment, because of the disease, and then we give them steroids as part of the chemotherapy. So are these children at a greater risk for developing a metabolic syndrome? If so, how to monitor and intervene early?
Thank you, ma'am. Thank you, organizers, for the opportunity. So as this is one of the important topics that is being discussed in almost most of the context, but in childhood survivors, again, it's one very important that we need to realize that they are more prone for metabolic syndrome, especially because of two aspects. One is because of the disease per se and the treatment. Most of the chemotherapy is toxic to the endothelium and it causes damage through the reactive oxygen species. So that is why Dr. Dheenadayalan told about the cardiovascular risk factors. So the endothelial damages starts from the treatment, but it's there at a baseline. When something extra tips the balance, then they go in for a full-blown problems. So, and to add that, we have problems like obesity. We know children, they are stuck to the mobile phones after the COVID era. So it's very common that the children are given much leeway during the treatment because they are going through treatment. The parents treat them differently and we are not able to get them out of the risky habits after that. So we see most of the harmful habits like food faddism. Many things are contributing. It's not just the steroids that cause it, but there are many other things, and the parents are not, lose the control over their children's habits once, even after they cross the treatment. So that is what we see in general. But having said that, the obesity, steroids definitely do contribute to it, apart from the other chemotherapy-related endothelial injury. So the other components like hypertension, impaired fasting blood sugar, all these are part of it. And it is seen in large studies across the countries that the incidence of metabolic syndrome is as high as 33.6%, noted in one of the French studies. So the risk factors mainly being the age at the time of diagnosis and the habits that they follow, and mainly the radiation therapy also adds to it because it causes much more damage than the chemotherapy. And steroids are a controversial area, but it is generally said that the dose of steroids that they receive and the duration of steroids that they receive definitely do have an impact, especially in children with leukemia where they have a long-term high-dose steroids. So the components of the metabolic syndrome are these. So, and these children as an adult as well, they definitely need regular health monitoring at least once a year for BP, blood sugar, lipid profile, and they should be motivated to have the healthy lifestyle in terms of food and physical exercises. Even after they complete the treatment, we start talking to them from the maintenance phase as well. So that gives them some motivation.
And partly contributed by the parents, because the children are suffering, they try to overdo a lot.
True. So this, we have standard guidelines nowadays because we, as Dr. Arun said, 80% are going to live normally. Most of the parents that they come, their first day they ask our question, okay, he will live, but will he live normally? We don't, it's very difficult to explain them what's normal. Most of us even are abnormal, but we need to tell them that yes, they are going to go back to normal life. So it is very important they actually concentrate on the other aspects of the health that they should be doing, which are even which should be followed by so-called normal adults, and which we should be doing. So that's the idea about it.
The other thing is, will my child be short? Will the height be affected? Or will she attain menarche? If it's a girl child, particularly in India, will she attain menarche if she's about 6 to 7 years? So I think Arun has already covered it. Can you tell us briefly the effects of radiation and how to monitor these?
Sure. So again, short stature is mainly a function of radiation, and menarche as a delayed puberty effect is mainly because of two things. It's either because of the radiation therapy, which can be because of pituitary dysfunction, or it could be a gonadal dysfunction. It could be both. It could be central or peripheral. And the general risk factors include the radiation therapy, which is seen in brain tumors, the head and neck sarcomas where thyroid is affected, Hodgkin's lymphoma where the thyroid is most likely exposed, alkylating agents like Dr. Arun highlighted, and the total body irradiation as we use in transplants, and brain surgeries, for the brain tumors where we involve the pituitary. All these can lead to the delayed puberty, and because of which they can have amenorrhea, but we do have treatment for all of these, and with the advances in the endocrinology and the hormone supplements, we do have a treatment for all these. In general, the leukemia and the solid tumors that we commonly see, we don't see most of them having a pubertal failure in general, but those who receive a radiation therapy more than 30 grade, which involves the pituitary, or if there is a germ cell tumor where they had to remove one ovary, where they had to be irradiated, the chemotherapy involves a lot of cisplatin and alkylating agents, yes, we have to worry about that. So anywhere the radiation which is more than 30 gray, as shown here, has a long-term impact on the hormone systems, and we again need to proactively monitor them and start supplementing them so that we can avoid some of the comorbidities.
And nowadays I find that most of the protocols, particularly standard risk, don't have radiation. That's how we have down-regulated IC.
We are trying to move away from the radiation-based regimens, like especially the Hodgkin's lymphoma, where children survive more. So we trying to replace the efficacy with better chemotherapeutic agents so that they don't face long-term side effects. And again, it's already shown. So failure to attain puberty is seen, but it's less often in the pediatric cancers. And more often during the treatment, when they come in adolescence, we see a cessation of menstrual cycles, which is usually transient. But once we complete the treatment, they can go back to the normal life. Infertility is definitely a concern, the hormonal function is separate from the fertility aspect. So the ovarian reserves are something which directly leads to the fertility. For that, Dr. Arun has already discussed the options to preserve. But in prepubertal children, it's hardly possible these days, because per se to preserve the ovarian tissue has a lot of implication, and of course the cost of that particular procedure would be 2 to 3 times higher than the leukemia treatment per se. So we are not in the practically era of doing it, but yes, there are options. But most of these children do well with estrogen hormonal therapies in the long run, especially the adolescents. And in our hospital, we have a practice of starting the adolescent girls who have entered the puberty on high dose GnRH analogs, so that the ovulation is suppressed during the chemotherapy, because they are not able to afford for the ovarian preservation or oocyte preservation. So we try to suppress the ovulation so that the amount of cells that are exposed to toxic chemotherapy is less. So that's the concept that we use. GnRH is not that costly. So hopefully we can salvage some of the remaining functioning ovum.
So then the most important issue when it comes to the child who's growing into an adolescence are the emotional and psychological issues. So I remember a day when I used to say there's an adolescent boy we treated who had a primary malignancy and then a secondary malignancy. He walked out of both, but then he didn't have enough hair on the head. When I told him, when I was talking casually, we just talked, and I told him, see, you've won 2 wars. This is a minor thing. He looked back at me and said, Madam, at your age, hair doesn't matter. At my age, being in an engineering college, no girl wants to come and sit next to me. So what are the emotional and psychological issues, and how do we tackle them?
So this is definitely a great concern in the adolescents, ma'am, especially, and even we have had a 6-year-old girl who refused to come for treatment for 1 week because we had to shave the hair. She had such a long hair. So, I mean, we think it's adolescent, but even a 5 or 6-year-old girl can have that. But yes, it is a problem. But in pediatric oncology, as we said, these are the transient concerns. We always try to proactively keep telling them that yes, you're going to lose it, but it is reversible. So that is the aspect that we keep trying to tell them. And of course, nobody feels bad when they actually do the head shaving for a religious reason. So that is how we try to connect it. And we always say them it's going to come back in the next 3 months once you stop the chemotherapy. So that aspect is there. But yes, there are a lot of other concerns, going to school, changing the school, change of houses. Many people are still worried about the stigmata. I think focused counseling would definitely help all of that. I would rather say seeing more of emotional and psychological issues and PTSD more than children we see, more than in the parents of the children who actually have. And we had 2 days ago, we had one of our follow-up patients in OPD who was treated for lymphoma. He had a fever of 2 days, abdomen pain, so they've done a scan, and there are some mesenteric lymph nodes which is not at all significant. I know they're panickingly coming from all the way from Tiruvannamalai running saying that is it lymphoma again. So it's already 5 years, but they are not able to come out of the fact that they've come out of the disease. So these are the things that we do come across, but the only option is we are again trying to involve the psycho-oncologists. There are many institutions like CMC Velu, TMH have focused psycho-oncologists to not after the treatment but to start counseling from the beginning of the treatment as an integrated therapy, so that they understand that yeah, they can go through and come out of it, and there is definitely a good quality of life after that. So I think focused counseling and reassurance is the only way. We have had situations when we had to ask few of our survivors who are willing to actually come and talk to the existing patients. We have done that for few of our patients, especially the adolescents. After they have come and talked, they are actually better. And we actually have few celebrities who have survived cancer. Of course, Yuvraj Singh is the classical example. We quote to many of the adolescents that if he can survive and do this, you can also do this. So these are some of the practical measures that we follow. But yes, definitely, as an oncologist, we don't have much time to sit with them, but the psychological interventions definitely will help.
Yes, I do agree. When a patient is sent into for an oncology consult, the moment they land outside your room, the panic starts, both for the parents and the children. Yes, Yuvraj, they are able to accept, but most of our people are not even able to. They keep saying, don't say the word CA and CER. They don't even want to stretch it and phonetically. So that's a long way for us to go. So this is what finally to optimize with so much of advances in oncology, so much of subspecialties or side-by-side specialties like endocrinologists, psychoanalysts, joining hands with the primary pediatrician who plays a very important role. So we would be probably in the future, not AI, the human brains, the human intelligence will take these children to run a happy family. This is probably a picture of the survivor should be like this. You won't know whether the girl was a survivor or the boy was a survivor. That's how we have to aim in future, though we might not be able to provide that for everybody. So this is possible, very much possible. with shared care between the referring primary pediatrician and the oncology units. So the take-home message is, yes, heartwarming, pat on the back. There is improved survival of pediatric malignancies, and we are marching towards providing better quality of life post-treatment. Lot of researches, everything is going on in individualizing treatment that has reached a pinnacle almost. So the next step that we are marching ahead is to maintain, give them a quality of life. So that requires a shared care between the pediatric population, the psychoanalyst, and the community at large. Thank you. Thank you.
Thank you, thank you, ma'am, and the panelists for an exhaustive discussion on questions which we may have to deal in future, as we are having lot of survivors of cancer. And thank you, ma'am. And we'll have the mementos at the memento place, ma'am. And with this, we come to the end of the academic session for today. It was very nice having all of you here for the first day of this conference, and you can relax in the evening on the sands of the marina, or you have got the markets around, you can do the shopping, and tomorrow please come back rejuvenated. We'll be very happy to be with you tomorrow. Thank you. Thank you.